Your doctor just told you that a tiny metal device is now permanently inside your heart, and you have no idea what that actually means for the rest of your life. Can you exercise? Can you fly? What happens if you miss a pill? What if the stent moves? Millions of Americans receive a coronary stent every single year, and most of them leave the hospital with a pamphlet, a bag of prescriptions, and more questions than answers. Today, I'm going to change that. We're going to cover everything: where stents came from, how they actually work inside your artery, what medications you absolutely cannot skip, and exactly how to live a full, active life after your procedure. Grab a coffee, sit back, and let's get into it. This video could genuinely save your life. First, let's go back to the beginning, because to understand life with a stent, you need to understand what your arteries looked like before one was placed. Think of your coronary arteries as pipes. Their job is to deliver oxygen-rich blood to your heart muscle 24 hours a day, 7 days a week, without stopping. Over time, due to high cholesterol, high blood pressure, smoking, diabetes, genetics, or a combination of all of these, fatty deposits called plaque begin to build up inside those pipes. This buildup is called atherosclerosis, and it's one of the leading killers in the United States. The plaque slowly narrows the artery, restricting blood flow. When the blockage reaches around 70%, your heart isn't getting enough oxygen during physical activity. That's when people start feeling chest pain, also known as angina. Tightness, pressure, shortness of breath, a warning signal your body is sending you. If the plaque suddenly ruptures, cracks open, a blood clot forms on top of it almost instantly. That clot can completely block the artery in a matter of minutes. That's a heart attack. That's a 911 emergency. And that's when every minute counts. If you receive a stent before a full blockage happens during a stable angina procedure, you are incredibly fortunate. You just dodged a major cardiac event. And if you did have a heart attack, the most critical window is within 4 to 6 hours. Every minute of blood flow restored is heart muscle saved, cells kept alive, future quality of life preserved. Now here's something most patients never learn, and it puts into perspective just how miraculous your stent really is. The very first coronary stent was implanted in 1986 in Toulouse, France, by cardiologists Ulrich Sigwart and Jacques Puel. This was a landmark moment in the history of medicine. That original stent was essentially a bare metal coil, revolutionary for its time, but primitive by today's standards. The procedure was nothing like what you experienced. In just 4 decades, stent technology has undergone a complete transformation. We went from a simple metal scaffold to what is essentially a precision-engineered biomedical implant. Think about that. 40 years ago, if you had a heart attack, there was no stent. You were treated with blood thinners and bed rest. If you survived, major open-heart bypass surgery was your main option, a procedure involving a large incision down your sternum, a heart-lung machine, and months of recovery. Today, less than 1% of coronary patients require bypass surgery. Everyone else can be treated through a small puncture in the wrist or groin, same day, go home tomorrow. That's the power of the stent. So what exactly is sitting inside your artery right now? Let me explain, because understanding this will make everything else in this video make sense. A modern coronary stent starts as a tiny tube of medical-grade metal, typically cobalt chromium or platinum chromium alloy. A laser cuts an intricate lattice pattern into the tube. That pattern is designed to give the stent maximum strength with the absolute minimum amount of metal. That stent is then mounted in a compressed state onto a tiny balloon at the end of a long, thin catheter. The whole system is only about 2 to 3 millimeters wide. During your procedure, that catheter was threaded through your artery, typically from an access point at your wrist, all the way to the blockage in your coronary artery. No large incision, no general anesthesia, no open chest surgery. Once in position, the balloon was inflated to pressures between 10 and 16 atmospheres, roughly 150 to 240 pounds per square inch. That pressure expanded the stent, crushing the plaque against the artery wall and opening the vessel. The balloon was then deflated and removed. The stent stayed behind, permanently, holding the artery open like a tiny, perfectly engineered scaffold. But here's where modern stents become truly remarkable. Today's stents are not just metal, they're drug-eluting stents, or DES. The outer surface is coated with a specialized polymer that contains a medication called a cytostatic agent. That drug is released slowly over weeks and months directly into the artery wall at precisely controlled doses. Its job is to prevent the surrounding tissue from growing too aggressively over the stent. Early bare metal stents had a major problem called restenosis. The artery would scar over and re-narrow, especially in diabetic patients. Drug-eluting stents have reduced this problem dramatically. The result is a device that is simultaneously a structural support, a drug delivery system, and a biological scaffold, all in something smaller than a pencil eraser. All right, this is the section I need you to watch very carefully because what I'm about to explain is the single most important thing you can do after receiving a stent. More important than diet, more important than exercise, more important than anything else. When your stent was first placed, your body didn't recognize it as part of you. It recognized it as a foreign object. And your body's natural response to a foreign object in your bloodstream form a clot around it. That's just basic biology, your immune and coagulation systems doing exactly what they're designed to do. Left untreated, that clot can block your stent, a catastrophic event called stent thrombosis. If that happens, you will have a severe heart attack. This is not a theoretical risk. This is a documented, life-threatening complication. This is exactly why you were prescribed 2 antiplatelet medications. In the United States, the standard regimen is called dual antiplatelet therapy, or DAPT. The 2 drugs are aspirin, typically 81 milligrams daily, and a P2Y12 inhibitor. The most common options are clopidogrel, Plavix, ticagrelor, Brilinta, or prasugrel, Effient. Your cardiologist chose the right one for you based on your specific situation. These 2 medications work through different pathways to prevent platelets, the tiny blood cells responsible for clotting, from sticking to your stent. They are complementary, they are synergistic. Together, they form a 2-layer defense. If one mechanism doesn't fully block the clotting signal, the other one catches it. That's the whole point of using 2 drugs instead of 1. Here is the rule that you must memorize. Do not miss a single dose. Missing even 1 day of your antiplatelet therapy can trigger stent thrombosis. This is not an exaggeration. The clotting risk doesn't go away until the stent has been fully incorporated into the artery wall, a process that takes approximately 12 months. For most patients, the DAPT regimen continues for 12 months, after which you'll likely transition to aspirin alone, or your cardiologist may advise stopping both, depending on your bleeding risk and heart health. That decision is always individualized. Before you run out of medication, refill your prescription. If there's any issue with your insurance or access, call your cardiologist's office immediately. In some cases, patient assistance programs exist for these medications. Do not let cost or access be the reason you miss a dose. Let's talk about something that causes enormous anxiety for stent patients, the fear that physical activity will damage the stent, dislodge it, or cause another cardiac event. Here is the reassuring truth. Once a stent is properly implanted, it is not going anywhere. During implantation, interventional cardiologists use intravascular ultrasound, a tiny ultrasound probe threaded inside the artery, to measure the exact diameter of your vessel and select a stent that fits with near-perfect precision. The stent is pressed firmly into the arterial wall at very high pressure. It is physically embedded into the tissue. It does not slide, migrate, or shift with normal daily activity, exercise, flying, heavy lifting, or anything else you might do in your everyday life. Now, can a stent theoretically be compressed? Yes. If you apply significant external force to a coronary stent, it can deform. But here's the key word: external. No normal activity generates anything close to the force required to compress a properly placed coronary stent. Coronary stents are specifically designed and placed to avoid anatomical positions where external compression could be an issue. Stents placed in peripheral arteries, like the carotid in your neck or the iliac in your pelvis, are made from different, non-crushable materials that return to their original shape even after repeated bending. So what can you actually do physically? Much more than you probably think. If you received your stent for stable angina before a heart attack occurred, and your heart function is otherwise normal, you can return to vigorous exercise: walking, cycling, swimming, even running. Under proper cardiac rehabilitation guidance, patients have completed half marathons after stent placement. If you did have a heart attack before your stent, the answer is still exercise, but the timeline and intensity depend on how much heart muscle was affected and your current ejection fraction. That's a conversation to have with your cardiologist during your follow-up visits. The bottom line: a stent is not a limitation. With proper medical management and cardiac rehab, most patients live fuller, more active lives after their stent than they did in the years before, because the angina is gone, the blood flow is restored, and the future is in their hands. Here's the part of this conversation that requires some honesty. Getting a stent removes the immediate danger, but it doesn't remove the disease. Your arteries didn't develop plaque randomly. Something caused it. And unless you address those causes, you are at significant risk of developing new blockages in the stented artery, in adjacent arteries, or anywhere else in your cardiovascular system. The number one modifiable risk factor is LDL cholesterol. High LDL is the fuel that feeds plaque formation. After a stent, the American Heart Association recommends a target LDL of less than 70 milligrams per deciliter, and for very high-risk patients, even lower than that. Most patients will be placed on a statin medication, like atorvastatin or rosuvastatin, at a high-intensity dose. This is not optional. This medication does not just lower cholesterol, it also stabilizes existing plaques, making them less likely to rupture. The second major risk factor is blood pressure. Hypertension damages arterial walls from the inside, creating the perfect conditions for plaque to form and accumulate. A target of less than 130/80 millimeters of mercury is the current standard of care after a cardiac event. Third is blood sugar control. Diabetes is one of the most aggressive drivers of atherosclerosis. If you have type 2 diabetes or prediabetes, aggressive management of your HbA1c is non-negotiable. Elevated blood sugar literally accelerates plaque growth. Fourth, and there is simply no diplomatic way to say this, if you smoke, you must stop. Smoking is one of the most powerful risk factors for coronary artery disease, stent restenosis, and cardiovascular mortality. There is no safe level of tobacco use for a stent patient. None. Diet plays a significant supporting role as well. A heart-healthy eating pattern, rich in vegetables, fruits, whole grains, lean proteins, and healthy fats, while limiting saturated fat, sodium, and added sugar, is the foundation your medications are built on, not a replacement for them. Cardiac rehabilitation is also something you should strongly consider if it hasn't already been recommended to you. It's a structured, monitored exercise and education program specifically designed for people who have had coronary procedures. Studies consistently show that patients who complete cardiac rehab have significantly better long-term outcomes. The goal is not to manage life around your stent. The goal is to change the environment inside your body so no new plaques ever form. That is the path to a long, healthy life. Here's something cardiologists don't talk about often enough: the psychological impact of receiving a stent. It is completely normal to feel anxious, fearful, or even depressed after a cardiac procedure. Many patients describe a heightened awareness of every chest sensation, a fear of physical activity, difficulty sleeping, or persistent worry about having another event. This is called cardiac anxiety, and it's extremely common. In some cases, it can be just as debilitating as the physical recovery itself. If you're experiencing these feelings, please tell your cardiologist or primary care physician. Cardiac psychology and counseling are legitimate, effective components of cardiac care, and there is absolutely no shame in asking for that support. Understanding your condition, as you're doing right now by watching this video, is one of the most effective ways to reduce fear and anxiety. Knowledge is genuinely therapeutic. The more you understand what's inside your body and why it works the way it does, the more confident and in control you will feel. Let's bring this all together. Here is your practical, actionable plan for thriving with a stent. Step 1. Never miss your antiplatelet medications. Set phone alarms. Use a pill organizer. Ask a family member to check in with you. Do whatever it takes for the full prescribed duration. Step 2. Take your statin every single day. Your LDL goal is less than 70 milligrams per deciliter. Get a lipid panel drawn at your next follow-up and know your numbers. Step 3. Monitor your blood pressure. Purchase a home blood pressure monitor. Log your readings. Bring that log to every cardiologist appointment. Step 4. Enroll in a cardiac rehabilitation program. Ask your cardiologist for a referral. Insurance covers it. Go. Step 5. If you smoke, stop. Talk to your doctor about cessation aids, medications, nicotine replacement therapy, behavioral support. All of these are available and effective. Step 6. Schedule and keep your follow-up appointments. Most cardiologists see stent patients at 1 month, 6 months, and 12 months post-procedure. These visits are where problems get caught early. Step 7. Know your warning signs. If you experience chest pain, chest pressure, shortness of breath, pain radiating to your jaw or left arm, or sudden dizziness, call 911 immediately. Do not drive yourself to the hospital. Do not wait and see. Call 911. Step 8. Build your support system. Share this information with your family. The people around you should understand your condition so they can support you, recognize warning signs, and know how to respond if needed. 30 years ago, none of this was possible. If you had a heart attack in the 1980s, you survived on luck, bed rest, and blood thinners. If you made it, you faced open heart surgery. Many people didn't make it at all. Today, a device smaller than a piece of macaroni is threaded to your heart through your wrist, and you're watching YouTube videos 2 days later. That is an almost unbelievable medical achievement, and you are living proof of it. Your stent is not a sentence. It is not the end of anything. It is an intervention, a second chance, and what you do with that chance is entirely up to you. Take your medications, move your body, address your risk factors, show up for your appointments, ask questions, and live your life fully, actively, and with gratitude for the tiny spring of metal that is keeping your heart open. Subscribe and hit the bell so you don't miss the next one. Thank you for watching, and here's to your good health. Goodbye.